the topic here is stent choices in congenital heart disease, and these are my disclosures. Now, we use stents in various areas of the heart defect, such as vessels like the aorta, pulmonary arteries, vena cava, pulmonary veins, right ventricular outflow tract, arterial ducts, and then there are many other miscellaneous locations. But the big issues when we're using stents are recoil of the vessel or kinking of the vessel, extrinsic obstruction, stretching of the vessel, and acute postoperative lesions. And these are the areas where we sometimes have to consider stent implantation. What is our ideal stent? Now, these are, the stents are needed really with a high radial strength in order to avoid recoil of the vessel. So what we want is a stent that is of low profile, with a low profile delivery system, and by engineering methods, pre-mounted stents are the only ones that you can get down to a lower profile than hand-mounted ones, manually crimped. Flexibility of the stents, good visibility on fluoroscopy, ability to redilate in the future to adult sizes. There should be minimal shortening of the stent. Hopefully, they could be retrievable. Sometimes you need an open cell design with wide struts in order to allow access into a side branch if you're covering them. The edges should be rounder rather than sharp in order to avoid perforations. That we should have the ability to reposition the stents, and preferably in the future they should be biodegradable. And I'm not going to be able to cover all of these aspects, but there isn't a single type of stent that fits into all of those ideals. So we have to mix and match in our practice. Well, we want stents in congenital heart disease that we can dilate to larger diameters. But the problem is engineering-wise, we cannot achieve all of these. And so the recent designs have been focusing on shortening of the stent, the radial strength profile, trackability, biodegradability, and rounded edges. We cannot, or the companies cannot, focus on all of the other areas that I've mentioned. The stents are made of a variety of metals, such as stainless steel 316L. That's predominantly used for balloon expandable stents. There are cobalt-based stents with chromium and molybdenum, tantalum stents, platinum stents with iridium or tungsten, nickel titanium alloys, other polymers, and then biodegradable materials. Most commonly used stents are the ones that we use on balloon expandable types, because these stents allow us to redilate at a later date as the patient grows. The other variety, the self-expanding stents, are really used very infrequently because of that limitation of further expansion. And so you would only use them when there is no need to keep pace with the growth of the child in various lesions. The cell design has played an important part now in stent technology. This is a Genesis stent with a closed cell. You can see this cell is completely closed. And this is a Valeo stent with open cells here and then closed cell here. And so it's the open cell design which has introduced flexibility in the stent. It allows access to the side branches if you overlap the origin of a side branch. Because of their open and closed cell design, there is less shortening. But the problem with open cells is that there is less scaffolding, and so more tissue can prolapse through the open cells, and possibly there may be a little bit more recoil. Now, we have a variety of balloon expandable stents available of different cell types. So, for example, Palmer's Genesis is a closed cell stent. IntraStent is an open cell, VisibPro an open cell. The Cheetham Platinum, whether it's bare or covered, is a closed cell. Andra stent is a variety or a hybrid of both closed and open cells, and Valeo stent is an open cell stent. Here are some other varieties of open cell stents. We don't use all of these in our practice, but the IntraStent and the Valeo are the main ones at the larger end of the scale, or the medium-sized vessels, and these are the much smaller vessels. The Jomed WaveMax used to be for medium-sized vessel as well. So here you see an IntraStent open cell stent, which I'll come back to later on. So the balloon expandable stents come in a variety. You can categorize them into small medium, large, and extra large, and the small ones are really expandable to only about 4 or 5 millimeter diameter. There is a wide range of stents available to us, and the technology is changing very frequently. Some of these are covered stents and others are bare, and these covered ones are tending to be used by the coronary interventionalists, adult cardiologists. Usually these stents are pre-mounted and predominantly used in coronary arteries and other peripheral vessels. Occasionally we might use these in ducts or right ventricular outflow tract stenting. The medium-sized stents, they're dilatable up to about 10 to 12 millimeters in diameter. The large ones up to about 18 millimeters, and the extra large ones up to about 25 millimeter diameter. So the medium ones are the Genesis medium and the VisiPro. You can dilate these up to 10 millimeters. The large ones, a variety of these are available, a bigger choice. Genesis XD, double strut LD, LD Mega, Andra Stent XL. These go up to 18 millimeters. The extra large ones, the Palmas 4014, 5014, LD Max, CP, and in particular, the Andra Stent XXL can be dilated to beyond, or certainly up to 25 millimeters, and the Andra Stent up to 30 millimeters. Now, what happens with small stents? We always ask the question, if we put a small stent in and over-dilate it, what will happen? Here is a Genesis stent that has been dilated to 5 millimeters, and as it is dilated more to 6 millimeters and 8 millimeters, you can see how there is shortening and there is distortion of the closed cells. But if you put a high-pressure balloon in a 4 millimeter stent, this is what happens. So an 8 millimeter balloon, when it's fully inflated before fracturing the stent, will only dilate this stent up to 6 millimeters diameter. Frank Ng, I'm grateful to him for some of these slides. He's done some excellent work on bench testing some of these stents. Here's a Genesis medium stent that has been dilated initially up to 10 millimeters, and you see that you can only achieve about 8 millimeter size. The larger stent has been dilated up to 14 millimeters, and when the balloon's deflated, it only inflates up to 12 millimeters in size. And this is before you attempt to fracture the stent in order to overcome those forces. Now, what happens to shortening? Well, the extra large stents, when they're dilated to 24 millimeters, these stents started out at the same sort of length. But notice the LD Max, the open cell one, has less shortening. The Palmas XL has a little bit more shortening at the same diameter. And the CP 8 Zig one shortens the most, having started with the same length as the other stents. Other stents that are up to 10 or 12 millimeter diameter, dilatable, OmniLink and the Valeo medium, these come pre-mounted up to 10 millimeter balloons, and the introducers are around 6 French. So now, if you've got infants who need stenting in vessels such as the pulmonary arteries, and you only need to stent the proximal part where the surgeons can get at later on, then these stents will have some important role. You can dilate them up to 12 millimeters without any shortening. But the Valeo stent seems to have become a little bit more useful. There is a Valeo medium and Valeo large. These are stainless steel stents with an open cell design. They're pre-mounted up to between 6 and 8 millimeters, need 6 French introducer, come in various lengths up to 56 millimeters. These medium ones can be dilated up to about 13 millimeters. Beyond that, they fracture. There is no foreshortening because of their open cell design. So these are quite useful stents. Now, Caroline Ovet summarized the different stents for comparison purposes. So, for example, on the left, Palmas Genesis available in different lengths here. These are unmounted stents, stainless steel, dilated up to 18 millimeters. Initially, their nominal diameter is 10 to 12 millimeters. These stents are flexible and have round edges, but obviously they have closed cells. They have very good radial strength. The shortening, however, is an issue. At 18 millimeter diameter, they may shorten up to about 38%, and beyond that, you can produce circumferential fractures. The LD Mega, not the LD Max, but the LD Mega comes in these lengths, unmounted again, stainless steel. nominal diameter is 9. You can dilate them up to 18 millimeters. They're flexible, open cells. Because of their design, there's slightly less radial strength than the Genesis, and shortening still occurs at the larger diameters. If you inflate from 9 to 18 in one attempt, there will be shortening of 35%. But if you serially dilate, so over a sequential dilatation up to 18 millimeters, then the shortening is much less. It's less than 10%. So if you're trying to put an LD mega in, you want to dilate it immediately. Now, remember, it will shorten quite a lot. If you dilate over a period of years, then there will be very little shortening. The Valeo large stent, not the medium one, but the large, is pre-mounted. The 9 and 10 millimeters, that comes through, passes through 7 French. And that Valeo large can be dilated up to adult size, 20 millimeters. It is very flexible because of its open cell. Once you dilate it up to 20, it has very poor radial strength. But if you dilate them serially, once again, there is very little shortening. But if you dilate them immediately, then there will be shortening. The extra large stents, such as the Palmas XL 4014 or 5014, again, they can be dilated up to 25 millimeters, closed cell design, very rigid strength, shortening of about 25% at the large diameter. The LD Max, again, unmounted stainless steel, up to 25 millimeter, open cell. Because of the design, it's flexible, and shortening is much less. It's less than 20%, especially when it's serially dilated up to the large size. The CP8 ZIG stent that is available in more choices, made of platinum iridium, has closed cells. It is flexible, but it has rounded edges, has very good radial strength, but at 24 millimeters, it will shorten by 35%. At smaller diameter, like 18, the shortening is about 14%. The Andra stent XL and XXL, and it's important to remember this is a recent introduction. It's unmounted, made of cobalt chromium. The XL can be dilated between 15 and 25 millimeters, and the XXL between 20 and 32 millimeters. So this is now introducing a lot more options for our congenital heart disease patients. It has a hybrid cell design. By that I mean it's got an open cell, closed cell design. It is flexible. Shortening of the XL is around 35% at 25 millimeters diameter, but less than 10% if it's dilated up to 18 millimeters. And if you dilate them serially, then the shortening is much less as well. What happens with closed cells of the stents, for example, when you dilate them immediately to bigger diameter compared with serial dilation? Well, here is a comparison for the Genesis XD stent. And you see here at 10 millimeters, 12, 14, 16, and 18 millimeters. And this has been dilated serially, and you can see the distortion at the larger diameter where there is shortening of 34% with these stents. But it's the cell shape that really changes. If you do serial dilatation, there is very little distortion of the cells of the LD mega stent, whereas if you dilate them directly to 18 millimeters from the nominal diameter, then you can see the distortion of these cells. Same thing with similar experiment with Valeo stents of serial dilatation from 10 right up to 20 millimeters, and you see at 20 millimeters complete distortion of the cells, loss of radial strength as a result, and a lot of shortening occurs. And so if you're using Valeo stent, you know that at the larger end, you will have to reinforce that stent at a future date. Now, we briefly mentioned about occlusion or covering of side branches. And again, this is where closed cell design is versus open cell design is important. Mega LD has an open cell design. Genesis and Palmas have closed cell designs, and if they're dilated to, you can pass a wire through the cells and dilate them up. These cells, closed cells, can only be dilated up to 6 millimeters, whereas the LD mega open cell can be dilated 10 millimeters or beyond. So if you're going to cover the origin of a side branch, then open cell design stent is much better because then you can go through the side branch and open up the cell to match the origin of the vessel. The Andro stent I'll briefly touch on now because it is an important addition to our armamentarium. As I said, it's a cobalt chromium stent with a hybrid cell design, making it more flexible. As I mentioned before, XL dilates up to 25, XXL to 32, and now is being used more frequently in congenital heart disease. The reason for its larger sizes is the design of it's a 12 zig for the XL and 15 zigs for the XXL, giving us a wider option. It is used for the right ventricular outflow tract pre-stenting in the Melody valve, but in that situation you only need to use XL. But if you're thinking of the Sapien valve, for example, then the XXL design is going to be better because it will dilate up to 32 millimeters. Now, up to recently, there were no fractures reported with XXL, but I gather from Joe DiGiovanni, he has had one, and there was one patient here with an Andro stent yesterday, I think, that had had a fracture in the right ventricular outflow tract. I missed that case, but I think that's correct. Cheatham Platinum stent is made of platinum. It's MRI compatible. I've mentioned that it can be dilated up to 24 millimeters, but the 10 zig stent, which is currently custom made, can be dilated up to 30 millimeters or more. So again, that is another option for if you want to dilate a stent above 24 millimeters. Covered stents, we've got a small selection of covered stents available to us. For example, the covered Cheatham Platinum stent, the Advanta V12 atrium stent, and the Joe stent, less used nowadays. This is more for peripheral vessels. The covered CP stent comes in unmounted as well as pre-mounted stents. There is a difference in the requirement of the introducer sheath. If you're using a bare stent, these tend to be about 2 French less than those that you need for introducing a covered CP stent. So a 24 millimeter covered CP stent requires a 14 French sheath. A bare stent requires a 12 French sheath. The Advanta V12 atrium, there are a few varieties of these, and you have to be careful which one you're going to use. For example, the LD comes in sizes of 12, 14, 16 millimeters. It's a 9 French sheath up to 11 French sheath requirement for this. Whatever the company says, these balloons tend to have a wing, and so it's much better to go 1 French above the recommendation in order to allow the balloon to come back in. They have a slightly odd lengths, 29, 41, and 61 millimeter long stents. They can be dilated up to 22 millimeters, but only if you do them in steps. Not if you implant the stent a 16 millimeter on a 20 millimeter balloon and inflate it, it will immediately recoil back down to about 16, maybe 17 millimeters, and that can be a problem in vessels that are pulsatile. And so you have to pick a lesion where you serially dilate this to a larger size. It is flexible, but it does recoil, and that's a big issue. The pre-mounted Advanta smaller stents that are up to 7 millimeter diameters only require 6 or 7 French. They can only really be redilated up to about 8 millimeters. The next one, the V12 atrium, which is pre-mounted up to 10 millimeters, also can be post-dilated really up to 12 millimeters. So if you're using a atrium stent in larger vessels, it is the atrium V12 LD that you want to use, not the normal RX or OTW. So you have to be careful and pick the right covered stent for these lesions. Self-expanding stents, less often used. They're very flexible, low profile, cannot be crushed. They conform to the curved vessels very nicely. They can be made of nitinol or cobalt chromium alloy. They have less radial strength than the balloon expandable stents that we use. Here is a picture of a wall stent, which is, as the covering is retracted, the stent opens up. There are other stents like the Smart Precise stent made of nitinol. There is the new version, which is probably opening up a few more horizons for us, which is the Optimed sinus superflex stent. These are self-expanding, very low profile, and they're being used more and more, and we've used them in hybrid procedures for stenting the duct in duct-dependent circulation. Here is a catalog of sinus superflex stents, which sizes from 7 millimeters to 9 millimeters. The length was 15 to 20, but more recently, the larger diameters are available in 24 millimeter lengths. And look at the profile. For all of these, you only need a 4 French introducer sheath, although if you want to do check angiograms, it's better to put a 5 French sheath because you can then do check angiograms. But the profile of this is such that it makes it much more easier and gentler on babies with congenital heart disease. The sinus repo DS stent is one that is being used for coarctation and even duct stenting as well, only available in 5 to 6 millimeter lengths, and diameters rather, and 9 millimeter lengths. Again, 4 French sheath requirement. I'll finish off with a word about biodegradable stents. The technology is still a long way away for us because the biodegradation materials degrade within a few weeks, if not days. There is the Ella stent, which is made in Czech Republic, which we've been using in bronchi, and it's made of polydiaxonone suture. The integrity is maintained for about 6 to 8 weeks, and it degrades over a 12-week period. And the profile is such that it needs a large sheath, but they do make custom-made stents for us, which we put in bronchi up to 6 to 8 millimeter diameter. So stents in congenital heart disease, well, these are some of the lesions that I mentioned, but we would use stents preferably in older children, adolescents, and adults for all of these lesions. For branch pulmonary arteries, obviously we stent at any age because we have to. Caval veins, preferably older children. Right ventricular outflow tracts, any age. Patent arterial ducts, obviously in neonates. Collaterals, any age. And bronchi, the problem is mostly in the early infancy period, and so we may have to use them in infants. And if we're using stents in bronchi, it's far better to use biodegradable stents rather than the regular ones. Thank you very much for your attention.